Great. Let's get started before someone comes here and then ask us to leave. So good morning. Thanks for coming, even though I said you don't have to come today. Yeah, I said that. The reason is that this topic is really minor. And I can tell you that only one or zero or two questions will be asked on the exam. If you're lucky, only one question will be asked. So it's not the highest priority topic. I have 40 slides today, but I can tell you only 2 slides are important. So I will tell you which one so that you can focus. And other parts you can just go through with me and then that'll be enough. No need to remember much. So today's topic is Micturition, and then we're gonna start with the functional anatomy. Although I know you guys know a lot about the anatomy, but let me review it. As you know, the urinary tract is, the function is for getting urine out of the kidney. The first part is pelvis, and that is collecting urine from the nephron, and then comes down to the ureter, and then going to the bladder, and going out from the urethra. So that's the basic anatomy fact. Before going any further, I want to remind you, I know you guys know this, but I want to remind you there are 3 different types of muscle tissues. In human body, one is skeletal muscle, and which you can control. It's under conscious control, like your arms and legs. And the second one, the smooth muscle cells, like muscle in a vessel. You cannot control. You cannot squeeze vessels with your conscious. So it's involuntary. And the last one is cardiac muscle, which is not relevant in this topic. But I just want to remind you that 2 different muscle types are relevant in the Micturition. So just keep in mind that the skeletal muscle is voluntary, and then smooth muscle cells is involuntary. Of course, urine can go through the tube. So you need a peristaltic contractions like a GI tract. But GI tract, food like a chunk like this. But in this case, urine, so it doesn't matter much. But still, peristaltic contraction helps to move the urine move forward. Only one point I wanna make is that parasympathetic stimulation promotes the peristaltic contractions, and then sympathetic stimulation inhibit peristaltic contractions. You don't have to remember this because this is the same as GI tract, so it's exactly the same way. Transport of the urine from the kidney. As you know, this is the nephron. Nephron makes the urine, and it comes down to minor calyx, and it goes to major calyx, and then collecting into the pelvis, and it goes down to ureter. Unlike a collecting tube, ureter doesn't have any function of reabsorption and secretion, so just tubes. So which means that urine in the bladder has the same composition as fluid flowing out of the collecting duct from the nephron. So nothing will change all the way from here to here. The quick review of the anatomy of the bladder. There are the 2 different the parts. The first one is the body here, and the second part is the neck. Neck is like a funnel-shaped extension like this. And inside the bladder, you can see like this, like a triangle shape. That is called trigon. And the surface is really smooth of trigon, and the other part is surface is rough. Those parts are called, I cannot pronounce, but Ragway, I cannot pronounce, you figure it out. Trigon is important because ureters connecting into the angle of the trigon, and the urine goes down. So the bladder has it's wrapped by strong muscle layers. That's called detrusor muscles. And action potential can spread through the detrusor muscle to cause contraction of the entire bladder at once. And then the pressure inside can reach to 40 to 60. If you remember, the heart can, can squeeze, and the pressure the heart can generate is around what? 120 or so, right? That's why systolic pressure is 120. So the bladder can generate 60 mmHg pressure, which means almost a half strength comparing with the heart. So it's quite strong. If you look at the layer, the fibers can go all the way, spiral, longitudinal, and circular. So with multiple directions, the bladder can contract. That's how the urine can come out really so strong from the urine, from the bladder. If going down a little bit, there's another muscle. It's called internal sphincter. That is also smooth muscle cells, and which is that you cannot control under conscious. And then naturally there is a tone here. It's a tonic contraction. So even at the baseline, this muscle is a little bit contracted. That way the urine cannot go through from the bladder, so preventing emptying of the bladder until you get to the bathroom. Also, this tension can help that the leftover in urethra can squeeze out. Another important muscle is external sphincter here. So in female case, it's in here, but in male case, it's here. So the important thing is that this is in urogenital diaphragm. Important thing is that this is skeletal muscle, which means that you can voluntarily control. So, normally, if you want to go bathroom, you can stop it. That's because you are contracting this muscle. Okay, enough for a little bit more. So the nervous system is very important for the control of micturition. There are three different nervous systems innovated in the bladder. The first one is parasympathetic nerve coming through the pelvic nerve. Any stretch inside the bladder can sense through this nervous fiber, and the motor system can control the constriction of detrusor and also internal sphincter. Second is sympathetic nervous system, which is coming through hypogastric nerves, and pain can sense through these nervous fibers. And the motor system mainly stimulates blood vessels rather than detrusor or internal muscle. And the last one is somatic skeletal muscle motor fiber. So it's a skeletal muscle motor. So that's why it's controlling external sphincter. Internal sphincter is once again smooth muscle cells, so it's controlled under parasympathetic nervous system. But in external sphincter is skeletal muscle, so it's under control of somatic nervous system. Right. So let's see, this is the parasympathetic nervous system. It's coming from S1 segments, S2, and then terminate on the ganglion of the wall of the bladder. And then sympathetic nervous system, it's a little bit higher. It's connecting to L2 segments of a spinal cord, and then through the hypogastric nervous system. And then the last one is somatic nervous system. Once again, that's a skeletal muscle controller. Yeah, those fibers are through the inside through pudendal, I don't know pronounce the nervous fiber, and controlling external sphincter. Okay, enough for this. So this is the first slide, important. I'm going to explain more this later, but for now I just summarize. So neurotransmitter mechanism regulate the lower urinary tract. So once again, there are three different nervous systems regulating the entire function of from bladder to the urethra. And first one is parasympathetic nervous system that release acetylcholine here. So this is parasympathetic, right? So it's release the acetylcholine, and then that binds to M3 muscarinic receptors. And you see this says plus. Plus means that stimulation of this receptor causes contraction. That's why it says plus. That's the parasympathetic system. And the next one is sympathetic nervous system. There are two branches. So you have to remember two things. The first one goes to the bladder, and noradrenaline is released, and then binds to beta-3 adrenergic receptors on the bladder. But that stimulation causes relaxation of the bladder. That's why it says minus. So there are two different nervous systems regulating bladder construction. M3 promotes contraction, beta-3 inhibits bladder contraction. And the other parts from sympathetic nervous system goes all the way to the urethra, and then noradrenaline is released, and then binds to alpha-1 receptor. It says plus, so this stimulation causes the construction of urethra, smooth muscle cells. The last one is somatic nervous system that goes to all the way to the external sphincter. So as I said, it's a skeletal muscle. So acetylcholine is released and then binds to nicotinic receptor. It says plus, so it's this stimulation of the receptor signaling causes squeeze the muscle of skeletal muscle. So those three those three nervous systems regulate the entire system, and then we're gonna look more detail in a minute. But this is a summary, and then this stomach means that if you wanna focus one or two slides before exam, yes.
Is there any action of beta-2 receptors?
No. That's a good question. Beta-3 normally you can find in fat adipocytes, so fat metabolism, and the other one is the bladder. Beta-1, Beta-2 more regulates hemodynamics like heart and vessels. And by the way, alpha-1 you can find in all the way the smooth muscle cells of systemic vasculatures, which we're gonna talk about this later. But okay, so now we can start talking about micturition, enough for anatomy. So micturition is the process by which urinary bladder empties when it becomes filled. And then there are two different steps. First one is filling, which means that the regular peristaltic contractions occurring 1 to 5 times per minute move the urine from the renal pelvis to the bladder, and then bladder fills progressively until the tension in its wall rises. That's filling. And emptying or voiding, sometimes they say, smooth muscle cells is arranged, longitudinal circular bundles, smooth muscle cells of the bladder means detrusor muscle. And then contraction of those muscles is mainly responsible for emptying the bladder during urination. That's a definition of micturition. Okay, so as you know, I get confused all the time for many things. So the thing that I always do is that develop my own way to understand, even though you don't find it on the textbook or LCOM. But here's what I know, what I do on this topic. So when you try to understand micturition, it's easier to separate emptying muscle and a filling muscle. Emptying muscle, of course, it's a muscle to squeeze the bladder. So in this case, the detrusor muscle, pushing the urine out here. The rest is more like a filling muscle because those sphincters are just a stopper of the urine, and then under normal condition, it's a little bit tense. Tension is there, so that the urine cannot come out. So preventing urine from passing down the urethra, but if it's necessary, those muscles are relaxed and then urine comes out. So if you think about it, then that's easier to understand. For example, during micturition, once again, the detrusor muscle contracts and that squeeze out the urine. And then those sphincters are relaxed. That way, urine passes out through the urethra. So urine remaining in urethra of the male is expelled by several contractions of the bulbocavernosous muscle, which is in the case of male here. For female, just depends on the gravity. Just by gravity it comes out. All the urine will be emptied, and then normally less than 5 ml left in the bladder. So that's the micturition mechanism. However, you have to think more, physiologically. So I'm going to show you both filling phase and then emptying phase. That way, easier to understand. So filling phase, sympathetic nervous system is dominant, which means that sympathetic nervous system is here, right? So which means that as no adrenaline is released and activate beta 3 receptor signaling, once again that inhibits bladder contraction. And at the same time, sympathetic nerves innervate urethra too, and then release adrenaline and then activate alpha 1 receptor. That way, because it says plus, it contracted this side. So basically, more relaxed in the bladder, and this is very contracted. That way, it's easier. The urine will be filled inside the bladder. That's a feeding phase. So once again, sympathetic nervous system is dominant. However, during the micturition, they switch around, and then parasympathetic active system can rule, which means that once again it's in here, parasympathetic activity. So it's released acetylcholine, binds to M3 muscarinic receptor, which promotes contraction of bladder detrusor cells. That's why it says plus. At the same time, sympathetic nervous system is deactivated. So it's not active here, so it's released. No, this part is inhibited. Not inhibited, but this is not active, so you more relaxed. That way, urine can come out of the bladder and then goes down all the way urethra. Here, it's more like, once again, this is a skeletal muscle, so it's up to you if you want to squeeze this muscle or not. Until you get to the bathroom, you can control this. So that's the micturition mechanism, but often the exam doesn't ask this, but more ask micturition reflex. That's a frequently asked content on the exam, which means that stretch receptor is on the surface of the bladder. It incends that, and the signal goes to the spinal cord through the parasympathetic nervous system, and then signal comes back. So that's a reflex. Here, this explaining the same thing, but it's more comprehensive. I found this figure somewhere, so let's see. The first, it says, number 1, stimulus activates receptor. So talking about stretch receptor on the surface of the bladder, send the signal. And then number 2, nerve impulse travels through sensory neuron to integration center in a spinal cord. So sent to here. And a nerve impulse is processed in integration center. Integration center is inside the spinal cord. And then motor impulse are conducted through motor neurons. So sent all the way. And then finally, effector responds to impulse from motor neuron. Smooth muscle cells contraction occurs in the bladder wall. So coming from the bladder, going to the spinal cord, and coming back to the bladder, that's the micturition reflex. Okay, the star mark, which means that this is my guess, just a guess. If you are asked any question on the exam, you might see something like this. You might guess, just a guess, I don't know. So this is the second slide that you may want to pay attention. This explains that micturition reflex. The x-axis says intravesicular volume. It means that volume inside the bladder, and y-axis is the pressure. So this is basically pressure volume curve. So there are 3 different phases. By the way, this can be recorded by a technique called cytometerogram, which is a catheter comes up from the urethra and it goes to the bladder, and then transducer can measure both volume and pressure. So this is available clinically too. So the first 1A means that the curve shows initial slight rise in pressure when the first increments in volume are produced. But it gets flatter because bladder is big enough to hold a lot of volume. So long, nearly flat segment comes next. That is 1B. But once so bladder volume is about 300 to 400 milliliter. So if it reaches to 400 milliliter or so, the pressure goes up all the way, and then triggers micturition. So, but if you look at closely, it's a little bit more complicated because the real micturition contraction occurs like this. So acute pressure wave are caused by micturition reflex, but spontaneously it relaxes, so it comes down. But this keeps happening because the urine comes from the kidney, and then this reflex coming more frequent and more strong. At the end, the systometrogram pressure goes up, and then you have to go to the bathroom. But you can still control. I'm talking about local reflex between bladder and then spinal cord, but that's not it. So the reflex is just between here and here. The signal at the same time can send to the brain. First part is pons, and then more like frontal lobe. And the central system is actually controlling, watching those reflex, which means that the micturition center in the frontal lobe sends inhibitory signals to the detrusor muscle to prevent the bladder from contracting. And so this sends a signal to inhibit all the way central lobe. By the way, the other one, pons, it's a more like a coordinator, just the muscle coordinate the detrusor contraction with external sphincter relaxation. So there are two major parts in the brain controlling this reflex. By the way, this is described in the textbook. You don't have to remember this, but the more recent research conducted using PET scan and then MRI shows that not just only two parts in the brain, multiple parts are activated during micturition. So it's real case is more complicated, but this is just a research paper, so you don't have to remember that. Just the truth is more complicated. Okay, so like I said, reflex is just local here, but the send signal all the way to the central frontal lobe, but it's inhibiting. But once it approves, then micturition occurs. That's the system. By the way, this reflex action occurs in babies, but inhibitory process begins to develop in infants from the age of 18 months as the central nervous system matures. So that's why you can control the micturition over 18 months. All right, so go to urinary problems. It's more like a clinical situation. Any questions so far? Okay, all right. So first is pain sensation. Like I said, pain sensation can sense through sympathetic nerves. But important thing is that these sympathetic nerves also innervate ureter, not just only bladder. In case kidney stones happen, it's that's really painful, right? This causes a lot of pain because the same sympathetic nerve innervates those ureter, and then pain goes back, and then the impulse causes sympathetic reflex back to the kidney and to constrict the renal arteries, thereby decreasing urine output from the kidney. This is called ureter-renal reflex, and then prevent flow of the fluid into the blocked ureter. So because of that, kidney does not really produce much of urine, and then try not to overfill in this space. But that's why you can sense the pain here by sympathetic nervous system. Another common situation you will definitely see is overreactive bladder. That is the inhibition impulses from the cortical micturition center is not sufficient. So due to stroke, brain tumors, Parkinsonism, so while brain tumors are not really common, but strokes and Parkinsonism are very common, then this feedback system is not working well. Then overreactive bladder is involuntary bladder contractions during its filling phase and then produce symptoms of urgency, frequency, and nocturnal enuresis. So because this inhibition is not working well, bladder contracts and then the water is leaked. So this is a condition you will see a lot in the hospital. Another case, the typical case is called stress incontinence. So stress incontinence is an involuntary loss of urine during increase in intra-abdominal pressure. When bladder is held in the correct position by the pelvic floor, the inner closing mechanism and the external sphincter of the bladder prevents leakage, which means that this is pelvic floor, and this is holding this bladder. And then, for example, if someone coughs, and then the pressure inside the abdominal cavity goes up, so that can move all the way down. But this pelvic floor at the same time can narrow this space. That prevents urine leakage from the bladder. But if this mechanism doesn't work well, then bladder prolapse like this, and then urine comes out all the way. That's called stress incontinence. By the way, this is happen. It says chronic cough means that the COPD patients, for example, and old elderly COPD patients coughing all the time, and then because they are old, their muscle is not strong enough, so that happens a lot. And in childbirth in females also could be a reason. Okay, so both overactive bladder and stress incontinence. How can you treat those patients? So this is a strategy. So now it's a problem with filling, right? Because urine, comes down. So that's a feeding problem. So once again, during a feeding phase, acetylcholine produces a bladder contraction. Not during a feeding phase, but remember acetylcholine produces a bladder contraction, while beta-3 adrenergic receptor stimulation relaxes bladder muscle, which means that if you antagonize acetylcholine signaling, then the bladder doesn't contract much. So that's why first approach is anticholinergic drugs, block the action of acetylcholine, so that reduce overactive bladder. So I listed the drugs names here. Another approach, of course, beta-3 receptor up here, and it negatively regulates bladder contraction which means that if you use selective beta-3 adrenergic receptor agonist and then stimulate this, then bladder is relaxed so that it prevents overactive bladder syndrome. So those three, make sense to treat overactive bladder. The last part is kind of funny. It's tricyclic antidepressants. So, urologists may give patients antidepressants. You may see that case. That's not because the patients are depressive. Urologists try to control this using antidepressants. The mechanism is kind of complicated, but the antidepressants have a kind of mixed function. Anticholinergic effects can be found in antidepressants. So that's why using this, you can cause the same effect as anticholinergic drugs. So those three are the major medications that you can use for both overactive bladder and as well as stress incontinence. So next disease you might see in the hospital is atonic bladder. So in this case, the sensory nerves fiber is destroyed by, let's say, crash injury. Because of that, so crash injury, this system is destroyed. So impaired impulse from spinal cord, impaired sensation too. So the reflex is not working, so the urine is filled more and more. And instead of emptying periodically, the bladder fills to capacity and then overflows. Sometimes this is called overflow incontinence. So that's one type. Another type you will definitely see is voiding difficulties by bladder outflow obstruction. Most typically it's enlarged prostate glands. BPH, for example, can obstruct the pathway here. Then, of course, symptoms of this problem could include bladder filling, such as frequency and urgency of micturition, and a poor stream, and varying degrees of retention of urine. So what you can do of those problems. So coming back to the neurotransmitters mechanisms, now the problem is emptying. So alpha adrenergic receptor stimulation contracts urethral smooth muscle cells. So if you use alpha adrenergic receptor blockers, then you can relax this muscle, and the alpha-1 adrenergic receptor blockers help relieve benign prostatic hyperplasia symptoms, but remember they do not reduce the size of prostate, but they can just help improve urine flow and reduce risk for bladder obstruction. By the way, alpha adrenergic receptor, once again, expressed on the vascular smooth muscle cells, right? So if you use this for the bladder problem, what would be the major side effects? Yes, hypotension, right? Because blocking vascular contraction, so it causes vasodilation. So that causes hypotension. So if you give patient this drug, you have to ask the patient, you have any dizziness or anything? If you stand up quick, you are okay, or those kind of things. If you're a good doctor, you have to care about those side effects. Okay, last 5 minutes. Let's do the case studies. By the way, I'm going to show 3 cases, but those are all real cases from Johns Hopkins hospitals. Nothing is made up, like a BBL. So, all right. Does anyone mind reading, please?
A 45-year-old man complained difficulty in starting micturition and swelling of the abdomen due to a distended bladder. His legs and feet had been numb for several weeks. There was a loss of perception and vibration in the legs. The cytometric reading showed a large bladder in which fluid was held at low pressure. There was inability to initiate contraction of the vesical muscle. The afferent nervous pathway for the bladder was injured.
Thank you. So, the chief complaint includes the problem with micturition. And you may think that is a disease, urological disease or something. And then if you are not a good doctor, just simply send a patient to the urologist. But if you look at it closely, the patient has loss of perception and vibration in legs. If you're careful enough, you can think more systemic problems rather than just only local bladder problems. So this case, this is not quiz, but this case was actually multiple sclerosis. I know you guys have not done neuro module yet, but this is immune system malfunction, and then that destroys myelin, which is a fatty acid substrate of the fiber, neurofiber, so it becomes like that. And it happens systemically, not just only one part of the body, it happens systemically. Means that it causes systemic symptoms, including muscle stiffness or spasm, paralysis, problem with bladder or GI, and mental changes, depression, and epilepsy. So the symptoms are not just only bladder, and then the symptoms have the systemic symptoms. So you could think this disease as a differential diagnosis. The next question, can anyone read it for me, please? Thank you.
This 66-year-old man came to the clinic complaining of weakness of the left foot and frequency and urgency of micturition. He noticed that micturition occurred as often as every 5 minutes. When he felt the desire, he had to answer it immediately or suffer incontinence. There was weakness in dorsiflexing the left foot. Diagnosis was left crural monoplegia. His blood Wassermann reaction was positive.
Thank you. Do you know Wassermann test?
No.
No, good. So chief complaint is, of course, the problem with micturition. But there was more than that. The weakness in the left foot, monoplasia, it's more like a neurological problems. Wassermann test most likely routinely performed in the hospital. That is a diagnostic test for syphilis using a specific antibody. So if the test is positive, currently or in the past, the patient has got infected with syphilis. By the way, syphilis causes a lot of neurological degeneration, and it's called Torbes dorsalis because this syphilis attacks the posterior side of the spinal cord, especially dorsal root is its favorite site to attack. And if this site is damaged, then depending on the which side part of spinal cord, it causes bladder problem. So if you see someone having a problem with micturition, you may want to check this too, just in case. The last case, can someone read it, please? Thank you.
On admission, a 65-year-old man was complaining of urgency, frequency, and nocturia of a year's duration, weakness of urinary stream, and feeling as if he never emptied the bladder. About 1 month before admission, he developed pain and stiffness in back, right shoulder, elbow, and wrist. He also complained of coldness and numbness of the right leg. He returned 2 months later, stating that he had developed an ability to empty the bladder. Examination shows the presence of a large nodule in the left thoracic wall. He had a carcinomatous metastases to the thoracic spine.
Thank you. So this is also the third case is also the same. The chief complaint is micturition problem, bladder problem. So you may wanna just send the patient to the urologist right away. But if if you are careful enough, he had numbness of the right leg and in the presence of a large nodule, and then chest X-ray shows metastasis. So in this case, this kind of patient you may see a lot, right? It's more common. This syphilis was common 100 years ago, but not anymore. Multiple sclerosis is not that, popular, but this is spinal metastatic tumors, which there are a lot of cancer patients out there, and you will definitely see. And urinary, actually, his urinary retention was due to compression of the cord at the 7th thoracic vertebra. And spine is the third most common site for metastatic cancer. So if cancer metastasizes like that, and it compresses the spinal cord, and it causes a lot of problems with micturition, and it causes loss of bladder. So, it's not necessary. Those three cases are not necessarily, the urologic problems. But my message here is that if you hear the complaints of bladder problems, don't just automatically assume that that's nothing to do with my specialties. I'm an internal medicine physician, so just send them to the urologist. Don't think like that. Just much more thing might be behind these symptoms. With that, I think that'll be it. So once again, just only 2 slides are important before exams. Just quickly scan 2 slides. That'll be enough, I think. Yes.
My question is for the micturition reflex. Is it just used? Can you go over that again?
It is local. Yeah, I know it was confusing. Because I showed you this.
Yeah.
The micturition reflex is just between here and here. So which means that this wave is between spinal cord and the bladder. And then the brain is more controlling, like here, just inhibiting.
So at what point is it considered a reflex? When
Yeah.
it's over the sacral nerves, or is it when it goes to the brain?
This is just not going to the brain. Brain is just keep inhibiting all the way up to here. But even though brain is inhibiting, that's why the urine doesn't come out. But this reflex is happening all the time between spine and bladder.
And it's unconscious.
Yeah. Any other questions? Good. Let me know if you have questions. And next, I'm not sure pathology is here. No?
She's not here. Could you go back to the slide with
Ah.
the alpha-1 receptor blockers, please?
Here?
So, they help with something like prostatic hyperplasia because they allow for the dilation of the urethra.
Yes. There are much more medication available in a real practice, but in this context, I thought it's easier just show alpha 1. Yes, so there are 4 different receptors that you may want to keep in mind. Because even though you could use beta-3 selective, in this case, for example, there are selective beta-3 agonists available, but used to be they used to use just regular base beta agonists, not the selective. Selective became available recently. If you don't use the selective agonist, then that causes a lot of problems. because beta 1 allergic receptor causes, faster heartbeat, and all hemodynamics will change. So once again, beta 3 allergic receptor is expressed on the bladder and fat. So fat normally doesn't cause a lot of side effects. So. All right, that's it. Thank you.